We'll turn our attention now to anxiety disorders. These include generalized anxiety, panic disorder, and phobias. In general, the neurotransmitters that are implicated include GABA, so our major inhibitory neurotransmitter, of which we see that there are deficits in this. The deficits in GABA mean that the amygdala can be too active, resulting in worry, greater anxiety, and so on. In addition, there appear to be deficits in the serotonin activity as well. So the drugs that are used to treat anxiety disorders include classically the benzodiazepines, which are GABA agonists. These are effective, but they're highly addictive, and so they are no longer the first choice of treatment. Individuals are now typically provided SSRI, selective serotonin reuptake inhibitors, instead. In terms of heritability, family and twin studies show that anxiety disorders are genetically influenced. Heritability ranges from 20 to 47%, depending on the particular disorder. There is a high comorbidity with other disorders. The overlap with mood disorders is high. About 50 to 60% of patients with major depression also have a history of one or more anxiety disorders. And panic disorder is found in 16% of bipolar patients. As we look at PTSD, post-traumatic stress disorder, we can see that heritability is about 30% in this particular disorder. It's a prolonged stress reaction to a traumatic event. It is not due to trauma solely, because there seem to be predisposing factors. In other words, not everybody who is exposed to a certain amount or severity of trauma develops PTSD. Predisposing factors are very important. Treatment can rely on exposure therapy, a safe and controlled exposure to elements of the traumatic event. Virtual reality is helpful in exposure therapy. It can help to provide a gradual immersion into a traumatic environment. And also, fear erasure is a possibility. Fear erasure is a therapeutic approach where the person might describe the traumatic event before an exposure therapy session is done, allowing the memory to get into a reconsolidation state and become more pliable. And this is shown to be a fairly effective treatment. There are new treatments. D-cycloserine, which regulates NMDA receptors in the amygdala, combined with virtual reality therapy, has been shown to reduce PTSD remission by about 50% after 6 months. So there is lots of hope for individuals who are suffering from PTSD. There are brain changes in PTSD. So if you look at discordant identical twins, where one develops PTSD and the other one does not, hippocampal volume is reduced in both twins, suggesting that this is a predisposing factor rather than a result of the PTSD. In addition, there is decreased medial prefrontal cortex activity and some evidence for decreased hippocampus activity as well. In contrast, the amygdala is hyperactive, making us worry more, right? And the anterior cingulate cortex is also hyperactive, increasing the amount of emotional distress. But let's take a look here at the hippocampus size, or the hippocampal volume of twins, one who was exposed to combat and the other one who was not. And you can see that they both tend to have smaller hippocampus volumes than individuals without PTSD. In fact, exposure to combat in these individuals, these twins without PTSD, did not do anything, it seems, to the size of the hippocampus. It's the same in their unexposed twins. So this seems to be a sign of a predisposing factor, a vulnerability to PTSD to have a smaller hippocampus. When we start looking at connectivity in the brain in individuals with anxiety disorders and levels of activity across different parts of the brain. We'll see that there are certainly some differences across different circuits that seem to contribute to the symptoms of anxiety. One is an increased activity in what's called a ventral attention network. The ventral attention network, shown here in this sort of greenish color, is a network that is involved in driving attention to stimuli in our environment. And if this area is too active, then it contributes to there being too much attention being driven to things and sort of that hyperarousal that is common in anxiety. In addition, there is enhanced activity in what's called a salience network. This network is involved in error detection, so detecting the difference between what you intended to do and what would have been an appropriate response. For example, in ourselves and as well as in other individuals' behavior. And so we can see that the salience network, shown here in purple, has activity in some in the temporal lobe, some parietal, and some frontal. There's also a frontal parietal network, which is involved in executive control. This network is less active in case of anxiety, as is the default mode network, which we've looked at before in Chapter 13. The default mode network, remember, is our series of brain structures that are active when our brain is sort of just at rest and when we're not focused on any particular task, but we're awake and alert and kind of sort of a little bit more inwardly focused perhaps. And so it results in there being poor self-monitoring, planning, and emotion regulation, things that are all affected in the case of anxiety disorders. Obsessive compulsive disorder involves abnormally high activity. Obsessive compulsive disorder involves abnormally high activity in the orbitofrontal cortex as well as the caudate nucleus. And if you remember, the caudate nucleus is part of the basal ganglia. This can occur after damage to the basal ganglia as well, so you can develop OCD as a result of damage to the basal ganglia. There is a genetic association between OCD and other anxiety disorders, which is not terribly surprising. And so we can see that the activity here in the caudate nucleus in the case of people with OCD, obsessive compulsive disorder, is more active than in individuals without OCD. Now, as a result of successful therapy, the caudate nucleus becomes less active. And so we can see that that area of the brain has become less active after successful therapy. The same benefit in terms of brain activity as well as symptoms is possible with drug therapy as well as behavioral therapy. So behavioral therapy is just as effective as drug therapy in the case of obsessive compulsive disorder. There are some disorders that are related to obsessive compulsive disorder. One is acral lick syndrome, excessive grooming. People who pull their hair are more likely to have relatives with obsessive compulsive disorder. It is treatable with SSRIs. And we can see that this is a condition that we can trace, in the case of a mouse, to a particular gene related to glutamate activity. Other disorders related to OCD include hoarding and Tourette's syndrome. And so you can see here that the area of the caudate nucleus in the case of Tourette's is also more active than in a control comparison individual. We'll turn our attention to personality disorders. We're going to look at borderline personality disorder briefly. Borderline personality disorder is estimated to have about a 40% heritability, and that leaves a lot of room for environmental influences and environmental risk factors. So once again, we're seeing the likely interplay between genes and environment leading to a particularly difficult personality disorder with relatively high suicide rate.